and preliminary clinical and/or KOH nature of fungus. So we have major two groups of antifungals, paulins and azole. Among the paulins, both amphotericin B and natamycins we are using it. And in the azole group, we are using like ketoconazole, fluconazole, itraconazole, and lately voriconazole. And these are in vitro sensitivity, but that's not often match with your clinical sensitivity pattern. So key points to remember, all antifungals are fungistatic, they are not fungicidal. Natamycin is the drug of choice for filamentous keratitis, especially against fusarium. Due to poor penetration, it is only effective in non-severe, more superficial keratitis. Amphotericin B is effective against candida and Aspergillus species. It is less effective against fusarium. Fluconazole shows good activity against candida species. Role of the scraping and debridement: on the first visit it is a must, then it is repeated depending upon the response, helps in decreasing the microbial load and also helps in penetration of topical antifungal agents. For dematicious fungus, probably it requires on every visit or maybe on alternate day. So there are like initial management like with monotherapy, superficial ulcer less than 5, less than 1/3 depth, no or trace hypopion. You can start with natamycin, mostly natamycin. Then you may have amphotericin B or voriconazole and other adjunct drugs. The MART trial shows that topical natamycin and topical voriconazole, they have said that natamycin treatment is better than voriconazole, and voriconazole should not be used as a monotherapy for filamentous keratitis. Then combination therapy when the ulcer is more than 5 mm, deep ulcer, endothelial plaque or endoexudate, presence of hypopion, there is scleral involvement, and maybe after 10 to 14 days when monotherapy is not effective, and combination of natamycin and voriconazole is maybe a better option. But amphotericin and natamycin, because they are in the same group, they do not have any synergistic effect. Role of systemic antifungal, same as combination therapy, one-eyed patient with scleral involvement, threatened perforation, and there are certain drugs like fluconazole, keratoconazole, itraconazole, and voriconazole. Voriconazole is most expensive. And there are systemic toxicity along with all antifungal, oral antifungals. So MART2 trial came, they have shown that topical natamycin and topical voriconazole plus minus oral voriconazole, and they have shown that oral treatment didn't decrease the rate of perforation or need for therapeutic PK. This was published in the last year. So this is very important trial. So role of oral voriconazole is not there much. How long to treat continue antifungal? Till the complete healing of the ulcer. Difficult to judge, especially with filamentous fungus. So the saying is continue for another 2 weeks when you feel that ulcer is healed. And stop treatment and again review the patient after 2 weeks for any recurrence. So role of intracameral and intracorneal injection. So we thought without this clearing of the anterior chamber, you remove all the exudates from the anterior chamber and then hydrate the wound, and intracameral and as well as intrastromal voriconazole you can inject surrounding the ulcer, so that there are concepts of doing this. And if you say there are indication like non-responsive to medical therapy, thick hypopion, and especially with endoexudates where the surface is healed, there are certain doses. And if you see that there are several efforts since 2007, and those are anecdotal. Sometimes somebody is saying it is effective, somebody said it is not effective. But we see that when this randomized study came, that we know that intracameral amphoby doesn't offer better the over topical antifungal therapy. Then again, we had experience also, some patient recovered. Then again, role of intracorneal, intracameral, voriconazole, and as the half-life is less, so it is not so much effective. There are certain reports of post-keratitis endophthalmitis. Then role of intrastromal, both are a little bit value is there, but again, that in deep keratitis only and mainly surrounding the ulcers. And again, this Namrata Sharma and their group, they have shown that intrastromal voriconazole didn't provide additional benefit over our topical voriconazole. I had certain patient like Sproof Candida, this patient combination of intracameral and voriconazole. So in summary, some of the studies showed that intracameral amphoby does work in conjunction, but need repeated injection. And complications, this is very important, uveitis, secondary glaucoma, iris neovascularization, and subsequent bleeding during therapeutic PK is very devastating. Similarly, intrastromal voriconazole doesn't have any role. Then this is a report published in Cornea by Elmer-2 group. They have shown we had a similar experience with this after dissect, and this patient responded beautifully only with voriconazole in the interface. So take-home message is timely standard medical treatment is the key of success of most fungal keratitis. In smaller superficial ulcers, monotherapy with natamycin is more important. Natamycin is most effective in fusarium. Amphotericin B is combined with natamycin in Aspergillus or Candida. Voriconazole is less effective in fusarium species. Combination of polines and azole have synergistic effect. Intracameral amphoby may have values in deep keratitis with endoexudate. Intrastromal voriconazole does have role in Candida infection, but not in filamentous fungus. Thank you very much for your kind.